Hello, everyone. My name is Sun Fu. I'm currently a PhD candidate at University of Minnesota. I'm also a senior data science analyst at Mayo Clinic. And today my talk is the implication of latent information quality to reproducibility of secondary use of electronic health record. The rapid growth and adoption of electronic health records has led this large expansion of longitudinal and dense clinical information. This transformation has enabled and held great promise for the secondary use of EHR to drive clinical research. And reproducibility in clinical research is crucial. Also, it's important in the field of biomedical informatics because knowledge-driven insight can be translated to patient care and practice. However, the definition of reproducibility has been broadly defined. One is the ability to obtain consistent result within the same data, method, and tools. Particular challenge for ensure reproducibility in EHR-based research is data quality related issues that can cause by non-standard data representation, ambiguous definition, missing or redundant documentation. As illustrated in the figure in the slides, because this primary function of EHR is centered around patient care rather than research, the priority of data documentation and reporting may vary significantly across providers and care settings. Thus, the care process can be iterative, complex, which can also involve multiple different stakeholders. Therefore, this inherent latent documentation bias and information variability in EHR can ultimately result in incomplete medical records, recording errors, and information misinterpretation. To address the above mentioned issues, we propose a multi-phase approach to examine potential barriers to reproducibility caused by different information quality. And we thus identified three main approaches. First, we will introduce a conceptual process of information collection and use. And then we'll talk about information quality measures help to quantify the process. Lastly, we will conduct a case study to illustrate the implementation and simulation. We first define that any information-related interaction in the secondary use as digital information extraction and transformation or DIET process. This DIET process is based on the conceptual model of information quality lifecycle, as shown in the image, including the key activities of information generation and information use. Specifically in the context of EHR, we included information documentation, extraction, organization, and representation. So the key advantage of information quality representation is that it can help capture the dynamic interaction between users and information in a sequential order. To assess the technical soundness of the DIET process, we come up with two measures. First is feasibility of whether it can complete original steps or information implementation feasibility. The second aspect is the variability of clinical outcome. The implication of these two measures and also the relationship between the primary implication are illustrated in the following table. To further understand the downstream impact of information quality on reproducibility, model simulation can be applied. The simulation can create synthetic medical data based on detailed analysis on real-world observational data. And previous studies suggest that agent-based simulation is suitable for EHR-based environment because it can capture the complex interactions between patient and provider. Based on the aforementioned methods and the materials, we conduct case study based on Mayo Clinic and Olmsted Medical Center. The participants were part of the biobank cohort, roughly about 57,000 participants, and 24,000 were consent at age of 65 or older. Our study focused on delirium, defined as a syndrome with symptoms of acute onset cognitive impairment, fluctuation course, tension, and psychomotor and circadian changes. The reason we chose delirium because two reasons. One is it is under-documented and reported because not every patient had a formal assessment for delirium diagnosis. Second reason is the heterogeneous definition of delirium, because there's no conclusive diagnostic test in clinical setting. We adopt existing published studies and definition for the case ascertainment of delirium. So which include confusion assessment methods, clinical diagnosis, nursing flow sheet, and previous developed and validated NLP algorithms. This slide summarizes the pragmatic implementation process of the case study, which include information collection, extraction, organization, and transformation, and representation. Information collection involved retrospectively retrieve various data topics, either through ETL process or manual data abstraction. Specifically, we utilize I2B2 data mart to help obtain patient demographic status through this cohort screening method. Additional data include appointment, diagnosis, flow sheet, clinic notes, or automatically retrieved through custom SQL language. Information extraction was applied involving our previous developed and validated NLP systems to extract CAM-specific features from patient clinical notes. Information representation and organization, we use the patient ID, encounter date to link patients across EHRs, and furthermore, all data are normalized from visit level to patient level. This slide summarizes four implementation for four information quality assessments, which include intrinsic information quality, accessibility information quality, representational, and contextual information quality. Intrinsic information quality were assessed with, using agreements on the case and non-case between three EHR-derived measures: CAM, ICD, and flow sheet. Accessibility information quality was evaluated through analyzing information accessibility and shareability across intra-institutional and inter-institution settings. We also define four levels of accessibility, include direct access, adaptive access, Pareto access, and no access. And specific definition can be found in the original manuscript. Representational information quality was assessed retrospectively by analyzing the inconsistency in data representation and identify the presence of information loss during the diet process. Lastly, due to the underdiagnosed nature, we measure and calculate the CAM missing rate to assess the contextual information quality. To illustrate the implication of information quality to reproducibility, we conduct simulation. Specifically, we focused on simulate the effects of poor accessibility information quality to clinical outcome variability. And we use holdout method by applying individual EHR-derived measures at a time and observing the associated outcomes. We use logistic regression to model each variables with outcome while adjusting age and sex and report odds ratio. The first results slide summarize the overall agreements of the three-week comparison between ICD, CAM, and CAM NLP and flow sheet. Overall, there was an agreement across three measures. Although CAM NLP yielded the highest agreement, there was no single data type comprehensively represented the delirium status. Thus, there was a strong indication that data quality assessment should be conducted prior to the information use. The workflow analysis indicate a varying level of accessibility information quality in both intra and inter-institutional setting. We observed that user-level resources had a better accessibility under inter-institutional setting, and site-specific ETL infrastructure may help promote internal data accessibility. And on the other hand, there were greater issues with information system level accessibility under both under the inter-institutional settings. This is made due to the privacy and regulatory concerns. The assessment of contextual information quality indicated a high level of variation in the documentation and reporting of the CAM features in both ICU and non-ICU settings. For example, delirium and encephalopathy are more likely to be documented in non-ICU settings, whereas the alternate mental status are more likely to be documented in the ICU's environment. This slide summarizes two types of ETL process based on the case study implementation. So the ETL process for structured data involve information transformation from non-relational to relational database, direct copy of information to create duplicate research mart, and a complete ETL process. We identify that amount of information loss is lower if the information transformation happens within two databases that were originally developed within the same vendor or share the same data standards, such as Chronicles and Epic Clarity. And direct information copy from Epic Clarity to MS SQL Server and UDP integration layer to attribute mark will observe that greater amount of information loss. This is due to the syntactic semantic standards. And for unstructured data, we observe that information loss of the syntactic structure of a document when converting RTF to plain text. The simulation of 5 different information sources on outcome of delirium patient indicated high variability of the estimated odds ratio. This suggests that when inaccurate or incomplete information sources are used as gold standard, bias or misclassification could occur, which emphasize that information quality has a significant effect on reproducibility. In summary, we discover various barriers to reproducibility, including inconsistent information documentation, information loss, and varying level of information accessibility. Thus, we recommend the implementation transparency and best practices should have more emphasized on the information resources prior to the information use. Our study was limited by only one case study, thus the generalizability of the finding is limited by the scope of the study. I would like to thank the co-authors and also my advisor, Dr. Hongfang Liu's guidance. Also, I'd like to thank the funding sources, NIA and the NIH. If you have additional questions, please feel free to contact me through the email presented here. And thank you very much for your attention and time.